Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Uptake and Economic Impact of First Cycle Colony Stimulating Factor Use During the Adjuvant Treatment of Breast Cancer by Don L. Hirschman et al. My name is Tom Smith, and I'm the Harry J. Duffy Family Professor of Palliative Medicine and Oncology at the Sidney Kimmel Comprehensive Cancer Center in Baltimore, Maryland. My oncologic specialty is breast cancer. My colleague in preparation of this report was Dr. Bruce Hillner, professor and eminent scholar at the Virginia Commonwealth University Massey Cancer Center in Richmond, Virginia. Dose-dense chemotherapy is a real advance in the adjuvant treatment of breast cancer. Intergroup trial C9741 and Cancer and Leukemia Group B trial 9741 gave chemotherapy every 2 weeks instead of every 3 weeks, made possible by using filgrastim subcutaneously for 10 days, starting on day 2 or 3, to allow white cell recovery a few days faster. We can still recall the excitement at the 2002 ASCO meeting and the favorable press in the 2003 JCO article. Surprisingly, the toxicity was no worse, and the disease-free survival and overall survival was better. For the whole group of patients, 4 years disease-free survival was 82% for the dose-dense regimens and 75% for the every 3-week regimens. The 3-year overall survival was 92% in the dose-dense regimens and 90% in the non-dose-dense regimens, statistically significant. In 2003, pegfilgrastim was introduced. Instead of patients giving themselves injections at home each day for 10 days, and the hassles of getting insurance approval and teaching people how to do this, we could bring the patient back on day 2 or 3 and get exactly the same effect, with no teaching, no insurance hassles, and a profitable injection. In this report, Hirschman and colleagues from Columbia studied the uptake of dose-dense chemotherapy and the use of growth factors in a Medicare population of breast cancer patients. The combination of a positive trial, lots of publicity, and the availability of pegfilgrastim allowed us to diffuse this new technology into practice very quickly. The number of patients getting dose-dense chemotherapy, defined as a cycle length of less than 21 days, combined with first cycle CSF use, increased rapidly after the ASCO meeting. Use of CSF in the first cycle increased from 6.4% to 46.9% during 1998 to 2005. And if adriamycin and paclitaxel were given, first cycle use rose from 4% to 68%. By 2005, 85% of this was pegfilgrastim. If the patient was node positive, she was more likely to get dose-dense chemotherapy, about 60% versus 30% if node negative. And consistent with the initial report, dose-dense chemotherapy was used equally in the ER-positive and ER-negative subgroups. By looking in the Medicare database for claims less than 21 days apart and matching this with the administration of first-cycle CSF, Dr. Hirschman could identify dose-dense chemotherapy. It is important to remember this is a database study done by linking Medicare claims to the SEER database. They did not have access to actual charts. So we know nothing about the actual doses, the dose intensity, or other important outcomes. But a lot has happened in the field of dose-dense adjuvant treatment since 2003. The data are now conclusive that dose-dense treatment helps ER-negative cancer, but not ER-positive cancer. The initial report noted that the benefit of dose-dense treatment was smaller in ER-positive women, a 19% reduction in the risk of recurrence versus a 32% reduction in the ER-negative women, which was not statistically significant. However, by 2006, in the 9741 study, there was only an 8% relative difference in ER-positive patients between the dose-dense and usual groups in disease-free and overall survival. Neither difference was statistically significant, and at most the absolute difference would be 1 person in 100. We should note that these were planned subset analyses, not fishing expeditions. A second 1,214 patient trial reported in 2005 showed no difference between every 2 and every 3 week FEC in ER-positive patients, while the dose-dense treatment was clearly better in ER-negative patients. Then in 2010, Bonilla and colleagues did a meta-analysis of these 2 trials of dose-dense adjuvant treatment and similarly found no benefit in ER-positive patients. The odds ratio was 0.92, again not significant. And again, there was a major benefit in ER-negative patients with an odds ratio for recurrence of 0.72. And there are side effects to giving chemotherapy and possibly CSF-supported treatment in this age group. Medicare-age women, compared to the younger women, have more treatment-related hematologic toxicity. The febrile neutropenia rate was 6% in older women on CLGB 9741 compared to 3% for younger women. Here, 15 to 20% of women had a febrile episode, not 6%, suggesting that Medicare-age women not on a clinical trial are harder to treat and have more complications. And the difference in febrile neutropenia with or without first-cycle CSF was only a few percent, not the 50% reduction in febrile neutropenia we're used to seeing. The rate of acute leukemia or myelodysplastic syndrome was 1.8% in women 65 or over, 3 times that of younger women. This is of concern because Hirschman's group has previously shown a hazard rate for acute leukemia or myelodysplastic syndrome after adjuvant breast cancer treatment with CSFs that was 2.1 compared to without CSFs. Clearly, we need more data on safety of CSFs in older women where the benefits are small in ER-positive women and could be outweighed by toxicity. Hirschman et al. Make the point that in 2005, Medicare paid $34 million for CSF in these ER-positive patients and got little, if no, benefit and potentially toxicity. Added to other work that shows as much as 90% of CSF is not used in accordance with guidelines, this is an opportunity to save substantial dollars and improve care. As a country, we represent 3% of the world's population, but we use 75% of the world's CSF. And at $2,200 an injection, it is expensive, so we have to use it wisely. In summary, we adopted dose-dense chemotherapy in women with high risks of recurrence. The key issue is how much benefit these women get in addition to the best current hormonal treatment. Now, as the evidence has become clearer, we need to maintain that treatment in ER-negative women, but not use it in ER-positive women. At the very least, if we use it, we need to explain to women how small the benefit is, a 0 to 8% difference in relative disease-free survival and overall survival, which it would amount to less than 1 in 100 women in the U.S. trial and no difference in the Italian trial, and the concerns about hematologic and infection toxicity. It's time to rethink our CSF's use in women with ER-positive cancer, especially women of Medicare age. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.